Welcome, everybody. This is Reid Rasmussen with Freshbenies, and we're here today to talk through the 3 myths of Medicare for All. And our goal today isn't to give you every answer of everything to do with Medicare for All and all of the political and legislative push for it, but really it's how do you have those clients who come to you, how do you have an informed and intelligent conversation with them about Medicare for All and how it may not be the panacea, with part of that goal to be to educate them and get them off of thinking that's the be-all and end-all solution so that you can turn around and actually implement a appropriate benefit plan with them this year. And that really is the goal out of it today. I've got a couple of guys on the line with me here helping, and Adam Hodge, many of you know Adam and work with him. He works in the orange states for us, and on the line today we've got some brokers who are appointed with us and working with Adam and Neil, and some folks who don't even know who Freshbenies is today, but brokers and consultants on the line here today. Adam, you want to say hello?
Yeah, hey, good afternoon, everyone. Thanks for jumping on here, and I think we got a lot of value that Reid's going to bring to you in the next 45 minutes or so, and hope you get a lot out of it. Look forward to chatting with you afterwards, seeing what you think. So have a good day.
Thanks. And Neil Kennish is in a unique position here because he, as well as I, he grew up in Canada and has chosen to spend his adult life here in the United States, so he's seen both systems work and has ties back to Canada to this day. So, Neil?
Yeah, just I'd echo what Adam said. Thanks so much for taking some time to learn about this hot topic. And for those of you that I know, good to see you again. And for those of you that are new, looking forward to working together. All
right. Thanks, guys. As we get going, a couple of housekeeping items. First of all, there's a Q&A panel here off to the right-hand side. And so please ask the questions that come up while we're talking about things. Number one, we'll try to get a couple of those at least answered at the end of the session today. And then number two, it'll give me some ideas of other blogs or other webinars or trainings that we might be able to do. So please interact with us there on the Q&A panel. And we will be doing a follow-up. We'll send a follow-up by the end of this week with a copy of these slides, if you like any of the screens that are on here, and a copy of the recording. So if there's others on your team who you'd like to get this information, that'll be available. And a couple of resources that we make reference to during the presentation. Okay? So with that, let's dive in here. And diving in, for me, like I said, I grew up in Canada. My degree was in health administration there. And when I moved to the States in 1991, it was shortly after that, in 1993, that the Clinton administration came in and they made a push for single-payer health care. And then it went silent for a while. And then in the early 2000s, it started to raise up as a conversation again. And then it went, well, silent, or the focus went onto the Affordable Care Act in 2010 when that got passed. And here we are again, and it's rising up as a topic again. And I'd like to point out one of the consistent things through the whole 28 years that I've lived in the United States. And that is that the reason I think this keeps coming up is because people don't feel in control with their health care. And as we've risen that out-of-pocket cost higher and higher and higher, now it's not the rare person who is feeling that they aren't able to be a consumer in the same way here in healthcare that they are in every other area of their life. And it's just made it tougher and tougher to actually have them feel like they're engaged with their health care. And the more that goes on, the more people say, well, we may as well just let the government run this for us. And I think that's a lot of what led to last August's Reuters poll, where 70% of Americans said they support Medicare for All. And I smacked myself in the head in August, and I just said, here we go again. Why is it that people think that this is going to solve it for them? Now, I'm inside the system, and everybody says we're tainted people. That it's a defensive measure for us to say that we don't want the government to run all of our health care for us. Yeah, sure, partly. But there's also some real things there, which is being from Canada, there's some very real opinions I have about the way that a government runs a healthcare system. And in the whole time that I've been in America, I've had a very specific opinion of why I don't think the Canadian system would fly in America, and yet it keeps being held up as a part of the reason to install a Medicare for All system. So this became a hot topic in the elections. Going into last November's elections, it was huge for getting the Democrats tied in. Heck, 2 years before, it had been huge for getting the Republicans in, and their slogan at the time was repeal and replace, and it was a great slogan, and it got them elected and got them in, and then they got in and realized, well, they didn't really have a policy to back it up, and that's a bit of the issue with the Democrats right now. A lot of them came in on Medicare for All, and we'll be talking about it leading up to the next presidential election, but it doesn't mean that they're all on the same page. They don't really have a policy that they're zeroing in on. But know this, healthcare is a hot topic, and you're going to be asked about it many, many times between now and, well, all this year and all next, for sure, leading into this next election. So what can you say about it? Last week I was in Washington, D.C. for NAHU's Capitol Conference, where 750 of us descended on Washington and all went and met with our different representatives. And representatives from both sides of the aisle are consistent that they want to talk about health care. Here were some pictures from last week. It was me and a couple of other brokers from Dallas, Cliff and Chuck. They both go with the philosophy of go beard or go home, but I didn't get the memo, so clean shaven over here. But we met on the top. This photo is with Van Taylor, who's a freshman Republican member of the House from Texas. And he had a lot of questions about what are the right ways to tweak some of the rules so that we can have a stable healthcare system. And then the other photo, not 2 minutes later, we happen to have a chance to meet Alexandria Ocasio-Cortez, AOC is what she goes by, a Democrat out of New York, who is one of the hugest proponents of having the government run everything to do with healthcare and many other things. Both of them have healthcare as a hot topic. Neither of them have the same value system, but both of them want to hear from us about what works and what doesn't work in the system. And when we look at your cross-section of clients, you've got some who are on that one side and some who are on the other and many in between. And the truth is, you better be able to at least talk about this as a topic without screaming CNN and Fox, right? So what we want to do today is when you look at this single payer topic, how do you address it and talk about it and not just say something as simple as this sign, which is single payer, it's what the people want? Well, is it what the people want? Yes, 70% of the people said they agreed with Medicare for All. But when you dive below the surface of what that actually means, and it is a fair question to ask, you start getting very different opinions. You get some people on one side who want the government to run everything to do with all healthcare funding in America. Some people want to have Medicare be an option that companies and individuals can buy into. Some want to have it be a public option, so if there happens to be a rural county that only has, let's say, one carrier plan option in it, they want the government's insurance company to be a carrier plan option in it. And others just want the ability that people who hit 55 to 65 could buy in early to Medicare if they wanted to. And across this whole spectrum, there's very, very different ideas. And it's a bit of what's going to play out over the next couple of years. Last week in Washington, on Thursday, the very first Medicare for All bill, it's called the Medicare for All Bill of 2019, got introduced into the House. You see a lot of activity in the House, especially leading up to the presidential election. It won't go anywhere. There's no bill will really get passed in the Senate or signed by the president before the next election. But there'll be a lot of activity there. And as has played out all the way through ACA, when activity hits the front pages of the newspapers, your clients and mine start asking us questions. And we need to be able to speak to what they're asking about. You know, it's interesting, this guy's sign said single payer, it's what the people want, and yet the truth is a one-size-fits-all system doesn't fit anybody's expectations. And most people are, when they hear about single payer and Medicare for All, I think what many of them have thought is they've thought about their discomfort with the system in the past, and most people, I think, believe based on what they're telling me, we could have a richer plan and I could pay less. They're not thinking, wow, if the government designs one healthcare system, one-size-fits-all system, we might really, this could be something of interest to me. And yet, in all my time of being here in America, people have pointed to other socialized medicine systems, and they've said, those systems are making it work. We can in America too. And so, but in all that time, most of us haven't gotten a whole lot of detail on the single payer system in other countries, on how it really works below the surface. So let's take a couple of minutes here, and I want to explain a few things about the way the Canadian system specifically works compared to America, because it allows you to dive into the conversation with a very specific system and the way that it works. And instead of talking theory of, hey, we should be able to do this for everybody, let's talk about how it actually works there. And that'll really be a foundation to help you have a sensible conversation with some folks, okay? So when we look at Canada and the United States, we're talking about, Canada's about a tenth of the size of America by population. It's about 36 million Canadians. I think that maybe it puts it at 11% of America's 325 million. It's about the same geography, although 90% of Canadians live within a 100-mile band of the United States. And Canada's that place that when you go to it, you'll go there and you'll say, gosh, this is kind of cool. They speak the language for the most part. There's some French on some signs. That's just kind of a little bit quaint. But, hey, there's some cool stuff up here. It's like going to your attic, right? You look around, you're like, hey, there's some cool stuff here. We should come up here more often. Canada has always lived in the shadow of America. And you might say Canada's just like one more state in America. Size-wise, they are. They're the size of California. But if you want to irritate a Canadian, tell them that you think of Canada just as one more state of the United States. They hate that. It's a little bit of when you live in the shadow of America and American news and politics and economy and social media now, print media and television media when I was growing up, you always knew that you weren't going to beat America on most things. But if you ever could, you'd love to be able to talk it up and say how great you did. And the Canadian, of course, talking to the American doesn't even know that you're in competition on anything. But it does come up as a point of pride for Canadians when they talk about their nationalized healthcare system, because it's been in place for a long time. It's been in place since 1967. That means 52 years, which I know because I was born in 1967. I was one of the first nationalized healthcare babies. And when Canada installed that, they had the luxury of having been able to look at what Britain had created a couple decades before. Right after the war, Britain had created a two-tiered healthcare system. And Canada didn't like it for the fact that it was a two-tiered system. And two-tiered meant that there was a government system, public hospitals, public clinics, public salary doctors, but then there was a completely separate private system there. And if people didn't want to go to the overcrowded facilities and work with the old technology and the old hospital rooms, et cetera, they could go off in the private market. And in Britain, if you can afford it, you're going to go to the private market rather than the public market. In Canada, they didn't like that. They said, hey, if we come up with a nationalized healthcare system, what's good for Joe, the poor guy, is going to be good for Joe, the prime minister, and we're going to have that same system work for everybody. And so they did what so few other socialized medicine countries have ever done, and they said if something's covered under that nationalized healthcare system, like let's say cancer treatment, which is, then it's illegal for a physician in Canada to provide cancer treatment to anybody outside of the nationalized healthcare system. So play within the boundary of this, fine, but there's no free market care because they didn't want the best quality doctors and care to be for the people who were the rich. So they didn't create a two-tiered system. So there's no free market. That's what I mean by this reference here on this slide. Whereas in America, we have a total free market system that covers about half of our country, and the other half of our country is covered by government programs, Medicare, Medicaid, the VA, and government employees, right? And so two different kind of footprints on how things are done. And when you look at the values between the two countries, in America, if we spoke about what's the core value here in America, well, it's freedom, right? freedom from religious persecution, freedom to succeed, freedom to fail, freedom of religion, apple pie and baseball, and you'd go on your discussions of what it means to be an American. And for a Canadian, at that same strength is this value of fairness. And Canadians don't like extreme success and they don't like extreme failure, so they really like to balance things out. And that's why they wanted a system that if they were going to create a healthcare system, it was going to work more equally for everybody. And here's the way that plays out, a few different ways. When you talk to a Canadian, they're just a little more willing to pay more in taxes, just look after me when the time comes. And that works for them because they're willing to wait their turn behind their neighbor if their neighbor is more deserving of their turn in line. And they're willing to do that because they have just a little bit more than American, a trust in government and a trust that somebody smarter than them is going to look out for their best interests. And when I think about 28 years of meeting Americans, and I haven't met all 325 million, but I've met a chunk, and that doesn't apply to any American that I've met. It's just, if we tell an American you have to wait your turn for some healthcare services, they're going to be saying, who's making that decision, and let me call them, and I'm going to tell them why I should do it my way. And don't tell me how to live my life or run my household. I'm going to do things my way. It's not your place to tell me, because it's this freedom mindset that we have in America. And I bring all of this up because there's always been this promise when the discussion of Medicare for All or single payer has come up, that in these other countries that have a single payer system, there's three arguments. Everyone has access to care in these other countries, they have better outcomes, and it costs less. And truthfully, if all three of these things were absolutely true, then I would say we should have moved to this system 25 years ago. And yet we haven't, and I'm still arguing against those. So let's dive into these three. In 25 years, these are the same three reasons that I keep hearing from folks. And so you'll notice them. I hear them discussed a little bit less and less, and some people just trying to say these days, hey, it's working in all these other countries, we just need to roll over to a system like theirs. Let's take a look at this first one on everyone has access. And 25 years ago when I first heard this debated, the statement was, in Canada, everyone has access to insurance. And in America, not necessarily everyone had access. There was pre-existing conditions, and there were some people who could not get access to insurance. But let's look at Canada, because in Canada, access to insurance doesn't necessarily mean that they have access to care, right? Dive into this. In 1993, the average wait time for a surgery, was 9.3 weeks. And today, last year, in 2018, 25 years later, it hit about more than doubled to 19.8 weeks for a service. And what's going on here? Well, Canada had 2 decades of build-up through the 60s, 70s, and into the late 80s. And about the time I was finishing college, healthcare inflation in Canada had gotten so bad. They had this unlimited supply and unlimited demand for care, and then they realized, wow, we really don't have an unlimited supply, and the country was running out of money because of healthcare inflation. And the government did what so few countries ever do, and that is they cut their budget. And so they dramatically cut their budget between 1988 and 1991 by 1/3 for healthcare. And since then, they've really worked to not increase taxes as much as they would like to on healthcare, because the demand is still there. But healthcare inflation still happened in Canada, just like it did elsewhere in the world. Now, they couldn't play it out by always just increasing rates like we did here in America. And as we look at the last 25 years, what happened? Our rates went up and our benefits had to get cut to kind of find a match. And in Canada, taxes went up a little bit, but the big thing that happened is services got cut. And one of the ways that those services got cut was by it taking longer and longer to get care. And that's really what this graph is representing is that Canada's wait times have skyrocketed in the last 25 years. Did inflation occur there? Absolutely. How did it play out? Way longer wait times. So these wait times are, if you were going to get a surgery by a specialist or a surgery by a general practitioner, let's say it was going to be a specialist, then this was the wait time from when you got your referral from your primary care physician to the specialist, and the specialist booked and completed a surgery. Or on the general practitioner side, it's when your general practitioner planned a surgery to when they could provide the surgery to you. And what you find in Canada is that emergency rooms and primary care physicians, very readily available, very accessible, and things work very well there. But basically, everything else that you're going to get done is going to be on the list. And you ask anybody who's lived in any other socialized medical country, and ask them about the list, and they'll tell you about how it's working out in their country. But you're on the list for virtually everything. You're on the list for lab tests. You're on the list for an MRI. You're on the list for a surgery. And in Canada, it's not first come, first served. It's you get your name on the list, and then somebody there's some entity, there's some committee that's unknown to really anybody is deciding who's the most deserving of that's on the list right now to get the services. And as you can see from this list, we're now at a 5-month wait time on average. So right now is the first week of March. If I needed a surgery today, on average it's going to be August by the time I get that surgery. August. 5 months. That means some people are getting it a little bit shorter and some people are getting it a little bit longer. Let's talk about how this plays out in a real scenario. So this is my father, Reid Rasmussen. This is us at last Christmas time. He's 83 years old. Good salt of the earth kind of guy. He was a Christmas tree farmer. He was a logger. He was a farmer. And in 2018, he had an issue that happens to a lot of guys that are over 80, and that is that he had a hernia. So he got a hernia in April, and he went to his doctor, and they booked him for a surgery in June. And then what happened was a couple of months out before June, he got a call from them, and they said, you know, at our hospital, we're only able to do one surgery a day. Between the surgeon's time and the facility time, that's all we're allowed to even do. And they didn't say it this way, but this was the story. Somebody more deserving than you needs this surgical space. And so they bumped him and they said, oh, well, we'll get you set up for July. So they rescheduled it for July. A couple weeks out from his July appointment, he got a call and they said, oh, you got bumped again. We're going to reschedule you for August. He was a few days out. He thought he was going to get there. And he was so frustrated when they got the call and they said, we're going to bump you again. And here's a guy that believes in this kind of a system and wants to make it work. Finally, on September 23rd, he had the service done. And this was for something as simple and as common as a hernia surgery. And I just want you to think about the people who are saying everybody wants single payer. Do you think the people that are marching are saying, yeah, everybody wants a 5-month wait time for something as simple and basic as a hernia surgery? By July and August, he wasn't able to even get out of a couch on his own. And that's a bit of what's going on there. So, yes, everybody in Canada has insurance, but it doesn't mean everybody has access to care. And the list, on the list today, there's 750,000 plus Canadians who are waiting for a surgery or some kind of a test. And what happens, of course, is many of them will cross the border into the United States because remember what we said, 90% of them live within 100 miles. So we can get there and have something done at lunch and be back home in time for dinner. And that's the outlet to the Canadian system for people who didn't want a two-tiered system, and yet there's availability of a two-tiered system. So on that first point, everyone has access. Yeah, everyone has access to insurance, but it doesn't mean any of the other countries are getting near the volume of services that are being done in America under their single-payer systems. Second point here is they have better outcomes. And I know the competitiveness American in you is saying, do they? I don't think they have better outcomes than us. what's interesting is they say you judge a society by how well you handle the least of us. And so we're going to take a look at babies at time of birth. We're going to look at how well we treat them, and at seniors at the time of death. And, amongst those who talk about other countries having better outcomes than Americans' system, there's two stats, and we're going to address both of them, and it's infant mortality rates and life expectancy. In 5 years, these are the couple of stats that have always been used to judge America versus these other countries. So you're wondering, what is our infant mortality rate in America, and how does it compare to Canada's? Well, per the graph here, we have in America, for every 1,000 live births, we have 5.9 deaths, babies who don't make it. And Canada's number is better than that. So yes, they did beat us on this by a little bit. Canada's is 4.7 deaths per 1,000 live births. And first of all, you say, okay, well, where's this data coming from? Well, down in the lower hand, left-hand side, I referenced that it's from the OECD, which is the Organization for Economic Cooperation and Development. It's this international organization that for decades has been tracking money data and healthcare data and demographic data in all these different countries. And they're sort of the clearinghouse. They collect all this data and try to get it to be comparable between countries. And then the stat is deaths per 1,000 live births. And down on the right-hand side, I referenced that. And what does that actually mean? Well, a live birth means that, what is it here? It's 3 o'clock today in Dallas, Texas right now. If a woman has a baby at 3 o'clock today in Dallas, Texas, if 3 o'clock tomorrow that baby is still alive, then that's considered a live birth. And if for some reason that baby is stillborn or survives a little bit but is not still alive in 24 hours, then it's not even considered a live birth. So this stat is saying for every 1,000 live births who make it past 24 hours, how many of them died after that? And that's the number of 5.9. Probably wouldn't surprise any of you if I were to give you the stats on some of amongst the Central America and European and Asian countries, and Canada and the United States, to hear that some of the highest rates are Mexico at 12.1 or Turkey or Chile. That probably wouldn't surprise you, right? It probably would surprise you if I told you the 3 best stats in the whole world amongst these countries that I referenced are Estonia at 2.3, Slovenia at 2.0, and Iceland at 0.7 deaths per 1,000 live births. And if I told you that, would some of you start to put up your hand and say, something might be wrong with the data? Well, I would agree with you. There probably is something wrong with the data. So let's take a look at what's really going on there. And let's use an example. In America, what we know is we can keep a baby alive at 22 weeks in America. 22 weeks gestation. That is a real premature birth, right? If a birth is happening like that, the doctor comes out, talks to the dad, talks to the family, and says, "Oh my gosh, we can't keep this baby in. Mom's having this baby. It's coming, but I just want to check with you. If we can do some extreme measures here, we can keep this baby alive, and it has a strong chance of growing to be a healthy child, but there's definitely going to be a fight on our hands, and this is going to be a very, very expensive baby with some special needs for a while. Are you prepared for that?" And in America, the answer always is, well, of course, do everything you can. And the way that conversation occurs in Canada is the doctor comes out to the family and says, "I'm sorry, the baby was coming, and we couldn't do anything for him." And in Canada, it's not even a choice by the family to try to have that baby. And so that baby isn't still alive in 24 hours, and it's not even making its way into the stats. So one of the reasons that America's number is 5.9 deaths is because we try harder to actually keep babies alive that in most other countries in the world, they don't throw $1 million at. Because that $1 million is going to pay for the next 100 babies who are going to get born, and they barely have the budget for that. So I would say if you're measuring outcomes or ethics, wouldn't you say we're prouder that our number actually includes some of the most difficult births in the whole world? And when you're comparing, the real point to make here is when you're comparing first world countries, Canada versus the U.S., this stat doesn't really dramatically define the quality of the healthcare system. It does between us and a third world country. You definitely want to bring that rate down from a third world country to these kind of numbers, but really it's not really a measure of the quality of outcome of exactly what's going on in healthcare, right? And in the same way, this question of life expectancy is similar. And I'll just tell you, for those of you living in America, your average lifespan expected right now at birth is 78.6 years, and for a Canadian, it's three times longer. And you're like, that cold, does it just make them stronger? What's the deal? The deal is Canadians, if you live in both places, you get to recognize they just move a little bit more, and they eat just a little bit less, and their lifestyle is just a little bit better. And when you consider the 3 years difference here, I would contest it doesn't really come down to what's going on when Joe is on that gurney and being wheeled into the hospital and the doctor's pounding on his chest and saying, live, damn it, and hooking him up to machines. This 3 years isn't indicative of the quality of the machines in Canada at that moment versus the quality of machines in America. And it's not indicative of who's paying the bill, right? It's indicative of how we're living our lives. Because we all know if we want to live a few more years in our own life, heck, we ourselves know that it's going to be about healthy issues, right? Is this in Canada or is this in America? And I know the palm trees kind of give it away. This is in America. Like, we are not the healthiest country in the world. Let me make that statement. We are the least healthy country in the entire first world of countries. We have more than 40% of our population now with a body mass index of over 30%. 10, 12 years ago when I was first looking into these stats, at that time the number was 33%. The second unhealthiest country in the world is Mexico at 33% today. Canada's at 28%, and the international average is 23%. We can't have the unhealthiest country in the world and expect that our stats for living longest are going to be better than other countries, right? Again, is it an indicator of our health, of our people, or is it an indicator of our health insurance system? I say it's the health of the people. And actually, even the reports from the OECD specify that a couple of the biggest issues that pop up that keep Americans a few years younger is gunshot deaths at young ages, dramatically keeps the years down. And in the last couple of years, the opioid epidemic is starting to have a result of an effect on the numbers. 80% of the world's opioid addictions and issues are occurring in America. So, better outcomes. When we're comparing first world countries, my summary is these aren't the ways to judge first world countries as far as outcomes. Great way to compare us versus third world countries, but when it comes to first world countries, you need to dive below the surface a little bit. Are these other countries, do they have a better healthcare system? I can just tell you. If you get cancer, you get heart disease, yes, there's some fine facilities in other countries, but I would not be running off to completely fitting inside the public healthcare models or the single payer systems in other countries and saying that that is better outcomes than America. But how about this last piece about it costing less? Hey, no question. We all know the stats. We know that 17.1% of the gross domestic product of the U.S., $3.5 trillion is now spent on healthcare every single year. And is Canada's less? Yep, Canada is 10.4. And there is no question America spends more on healthcare per capita than any other country in the world. But then again, we're the richest country in the world. We spend more than every other country on everything that we choose to spend on. And my question back would be, what should the right number be? Should it be 15? Because we can get to 15 by just making some care illegal like the Canadians did. Hey, between Canada and the United States, both countries spend about 9% of their GDP is coming from taxation and going into government programs. In Canada, they built a nationalized healthcare system that was this level for everybody. And in America, we didn't make it for everybody. We made it for our poor, our elderly, our VA, our veterans, and our government workers. But one of the things that's different between Canada and the United States that falsely keeps their number down is of those 750,000 Canadians who are waiting for a service or a surgery today, where some of them come across the border to the United States to the tunes of tens of thousands a year, those numbers for the cost of that care doesn't show up down here in Canada's number. Rather, those Canadians who come across the border and spend their money in the American healthcare system, those dollars actually show up under America's number. But it is what it is. What I would say is I don't think we're not saying we want to legislatively force the number to be less. We just know people are saying, we're spending a lot of money. Are we getting the best that we can? And for the people who are promoting that one entity, Medicare for All, or a single payer system, can provide access to all the care that we get and get better outcomes and have it cost less, it's a fallacy. And it's important for you to understand that, because if that's a fallacy, then all of the rest of this promise of single payer, it's what the people want, goes away. And people start to realize, oh, you're right, a one-size-fits-all system, that isn't what I wanted, and that's not going to meet my expectations. A one-size-fits-all system isn't what the people want. And I keep using this phrase, one-size-fits-all, because it's such a great phrase that as you bring it up with folks, they very quickly say, no, that's not what I want. And and as you start to dive into, well, what do you want? You'll find out that a lot of people, when they discuss it, they actually want a free market system. They just want a little bit more control of their health care. If we were to go to a single payer system, what would we get? Well, no question. People would be forced to wait for care. It happens in every single country in the world, except for America. Well, even here, under some models, right, we're waiting for care. It would restrict research and development, because one of the easiest ways to cut down that 17.1% is to cut billions of dollars from R&D that's being spent by government programs. We are the R&D department for the world. There's no question it would hike taxes. The latest judge on what a Medicare for All program would cost is $32 trillion over a 10-year period of time. There's nothing about that that's all just going to be paid for by the rich. It will affect taxes across the board. It would ration prescription drugs, because it's one of the biggest chunks of healthcare spending these days, and there's no end in sight on the advancements on specialty drugs, but there's no way that we would be able to pay for all those out of a single payer system. And it's not the item to bring up to anybody you're debating this with outside of people inside our industry, but it would destroy millions of jobs. No question. Those of us that work in the free market system of healthcare, our jobs would go away. The reason it doesn't matter to others is they'd say, well, there's going to be plenty of government jobs as we create a government system. So just quit what you're doing and go over there, and it all evens out in the wash, somebody else might say. But the biggest thing with single payer discussions that I don't like is that it's a complete distraction from people actually dealing with the issues of the day. For those of us that are inside the system, it's a distraction from us coming up with what is the best things that we can do with genetic testing, and ethically what care should we be providing and paying for, and what are the best practices that we can work with. And quite honestly, for those of us that are inside the system, we need to quickly and dramatically change up the way that we pay for care in this system. I mean, it's just a completely jacked system, right? And so some of you're out trying to roll out an idea to an employer that involves reference-based pricing or value-based insurance design, and you've got employers say, my people are going to complain about that. You know what? Tell you what, I'm hearing that people are going to go to a single-payer system anyhow, and this Medicare for All is sounding good. Tell you what, let's just wait for that. I'm not going to implement any of these new ideas. It would be too much disruption for my people. Well, if you want disruption, then just wait for the entire system to be disrupted. But that's why I think it's a distraction. We need to get people off of thinking that that's the only solution. Now, some of you are going to say, well, Reid, I want more resources. Where else can I go for this? I'm not trying to say I have the answer on how to run the whole American healthcare system, but this podcast, fixinghealthcarepodcast.com, is an interesting discussion. These guys get different theorists together and futurists and professors, and they say, hey, if you were going to fix the American system, how would you do it? And go back to January 6th. Ian Morrison was interviewed, and Ian Morrison is a guy who I think an awful lot like. He's from Scotland. He lived in Canada for a while. He lives in California now. He's a futurist. He's a consultant on healthcare. And I agree with very much of what he says about the way healthcare systems work in other countries and how you look at what you value so you can build a system that's appropriate for America. So that's an interesting podcast. And then this other organization, the Partnership for America's Healthcare Future, they're much more sort of feet on the ground. What's the issue of the day based upon the latest bill that came out or the latest article that hit U.S. News and World Report or the USA Today or whatever the topic of the day is? These folks are pulling podcasts and infographics and writing articles around the very specifics of what's going to come down each month as we go forward. So if you're looking for some resources that can help you be prepared to talk to the media or talk to your clients about the latest issues, that'll be a great resource for you. But let me go back to where I started, which is we've allowed our system to get complicated. We've allowed our clients to feel out of control. We tell them to go be a better consumer, but we haven't helped them, we haven't provided them with tools to help them be a better consumer. And as a result, we've got a country where, at least as of last August, 70% of the people were willing to say, let's just turn it all over to a Medicare For All system. That's on us. If we don't help our clients get more in control of their healthcare system, they're going to be happy to turn it over to the government. And really, this was the impetus that even started me when the Affordable Care Act was ramping up to start our company, freshbenies, where we knew that there were practical tools that help people control their healthcare. Telehealth services, specialist visits online, advocacy services to help people navigate the system, consumerism networks to save on some of the things that are getting ripped out of the plans, and then to wrap the whole thing in a member engagement campaign so that it would get used a lot so that we truly could have an effect on helping people control their dime, control their time, control their peace of mind. And instead of just tossing out a few tools and going, hey, we don't care whether you actually use any of these things, freshbenies, we made sure our services are getting used. Some of you know this with us, and you have many clients with us, and we appreciate the business with you. Some of you don't even know what we're here in business for, and it's this, to truly help people control their health care. That's why we're getting 35 times the usage of what some of our biggest competitors are getting for usage. Because this stuff matters. Because if we can help people actually feel in control of their health care and be empowered, they're not going to make some of the same decisions. So your takeaways today would be, number one, engage the single-payer discussion with your clients, with people at that next dinner party you're at on a Saturday night, and they say, oh, you're in healthcare? Let's have a conversation here. Because what we've seen is the stats do prove out. If you'll engage the conversation with people, most people actually will turn away from agreeing that a one-size-fits-all system works. So do that. Second, support stabilizing measures. What do I mean by this? So talk to your legislators in your state and in D.C. about changing up the flavor of healthcare, and let's make some of the fixes that are going to stabilize the marketplace. They're going to keep people engaged in their healthcare in the right way. And if you're not a member of the National Association of Health Underwriters, you need to just go to nahu.org, sign up today, and be involved in the process, because it's our industry to win and it's our industry to lose. And then the third thing you've got to help your clients control their health care today. So if you're not working with us at Fresh Bennies yet, I hope you would give us the chance to prove to you how awesome that can be to help people feel more in control. Because if they're feeling more in control, they aren't going to fall for some of these promises coming from others. Because Medicare for All, some people think it's what the people want. It's not what the people want. I hope this was a valuable discussion for you. And it was my version of a discussion around Medicare for All and how you might view it. If there's any questions, Neil, Adam, any questions come in that we can address here?
Not specifically on this one, Reid. I think one, that we talked about on a previous webinar is dealing with different generations, right? And people that have different perspectives and values. And we'd had a question specifically about millennials and how to address, they're having a different notion of what Medicare for All would look like. I think that'd be a good one just to kind of quickly cover.
Yeah, there's no question. The way you're going to have this conversation with a millennial is very different than you are with, I was talking earlier today with somebody who's 76 years old, and the view of everything to him is Medicare. And the view of everything to a 28-year-old like AOC, who I had the picture of, who's in the House now and saying she wants a single-payer system, no question. When we were all in our 20s, we thought the government should pay for an awful lot more as well. And we thought others should pay a little bit more for us to have a better lifestyle. And no question, it's tougher. I think that's where I found a lot of value in talking about these other countries, much in the way that we address the conversation today, to say, well, to ask questions. Why do you think this should be done? And their answer will probably be, well, all these other countries are doing it, and it seems to work for them. Well, let's talk about another country, and you actually are getting them to look below the surface on how some of these other countries' systems actually work. For them to be able to take a step back, they're looking at somebody else's system instead of their own, and they could say, well, yeah, I don't want a 5-month wait time to get a surgery, but the government should just pay for this. But you can kind of at least get them far enough along in the conversation where you've spoken about values, what was important to them, you engage them in the conversation instead of just yelling at them, hey, it's not going to work, and we can't pay for it all. Does that help?
Yeah, I think that's great.
Good. Like I said, I will send out a copy of the slides, this recording, and some of the resources that I referenced inside of here. Please let us know if there's other pieces of this conversation that you'd like, and you let us know how we can help you. Y'all have a great day. Thanks.